This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
All right, good afternoon, everyone. Thank you for joining us for our HealthyU Webinar Series. Today's topic is depression and suicide awareness. At any time during the presentation, feel free to enter any questions you have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes. As always, your questions will remain anonymous. Today's presenters, we have Dr. Jenna Taglienti, Dr. Joanna Stanchek, and Dr. Megan Oswald. Dr. Taglienti graduated from State University of New York at Buffalo Medical School and completed her psychiatry residency at State University of New York at Stony Brook, where she served as chief resident. She currently serves as program director for the psychiatry residency program and medical director of the mental health clinic. She's an assistant professor at Zucker Hofstra School of Medicine and is board certified in adult psychiatry and has been a Mather since 2016. Dr. Stanchek comes to Mather Hospital after completing medical school at the American University of Antigua and her residency at Zucker School of Medicine, Northwell Health at Mather Hospital. She's the associate program director of the psychiatry resident program and serves as the adult inpatient unit, psychiatric attending and outpatient resident clinic psychiatrist. Dr. Oswald completed dental school at Case Western Reserve University, followed by medical school at Oregon Health Science University. She's currently a resident in psychiatry at Zucker School of Medicine, Northwell Health at Mather. Prior to beginning her psychiatry residency, she trained as an oral maxillofacial surgery resident and worked in addiction psychiatry research at Oregon Health Science University and Portland VA Medical Center. She hopes to pursue fellowship training in consult liaison psychiatry or forensics. Her primary clinical research and advocacy interests are in addiction psychiatry, consultational liaison psychiatry, forensics, and veteran mental health. Well, thank you all so much for presenting today. If you could go ahead and pull up your presentation, the floor is all yours.
Make introductions. I'm Dr. Oswald. I'm a psychiatry resident, and I have here with me, behind me, with blonde hair, is Dr. Taglienti and Dr. Stanchek. Hi.
Can you guys see it?
Yes.
Okay, perfect.
Okay, so today we're going to be talking about depression and suicide. How we're going to go through it is first we'll talk about depression, just the statistics on it, how to define it, how to recognize it, risk factors for depression, and then we'll talk about more traditional treatment options and then some of the newer alternative treatment methods. And then we'll go through suicide in a similar fashion. We'll go through statistics, risk factors, warning signs and protective factors for suicide, and then the importance of reducing access to fatal means. Next slide. Okay. So as far as depression, worldwide, there's 300 million people annually who experience depression. In the US, there's 3.1 million people between the ages of 12 and 17 who experience at least one major depressive episode in the past year. The median age of onset is 32.5, so older than a lot of people would expect for the first episode of depression. It is more common in women than men, with 8.7% women have depression versus 5.3% of men. And suicide is the second leading cause of death among people ages 10 to 34. And it's important to note that 50% of people who are diagnosed with depression also have an underlying anxiety disorder as well, so they go hand in hand. And the good news is that the good news is depression is very treatable, but more than a third of adults who have depression do not receive any treatment. Next slide. So risk factors. One of the biggest risk factors is genetics. If you have a first-degree relative that has a mood disorder like depression or anxiety, you're a third as likely as someone who doesn't to experience an episode of depression in your life. Also, your brain chemistry, which is something that you can't really control. Again, that kind of relates to genetics. Experiencing trauma, whether it's early childhood trauma or later trauma, can lead to episodes of depression. Life events or stressors, things like changes in relationship status, financial difficulties, changes in like location, moving, things like that can affect. Conflict, difficulties in relationships, whether with family, friends, significant others, other illnesses, whether it is other psychiatric illnesses, such as anxiety disorder or ADHD, or other physical illnesses, pain being an important one, that can lead to depressive episodes. One's gender identity or sexual orientation can put people at higher risk for depression. And then another important thing is using drugs and alcohol can worsen or precipitate depression. Next slide. So how to recognize the symptoms of depression, whether it's in yourself or someone that you care about. You often see changes in sleep. That can be sleeping a lot more, or it can be sleeping less. Changes in appetite can also be similar to sleep, where it can be eating more or eating less. The depression can lead to a lack of concentration, so making it harder to complete simple everyday tasks, which is also worsened by often having a loss of energy, where things as simple as, brushing your teeth or getting out of bed to take a shower can feel like the largest task that you have to accomplish. Lack of interest in other activities, so hobbies, spending time with friends and family, even things like going to work become something that's really hard to do, and you just really don't find any joy in those activities. You can have feelings of hopelessness or guilt, a lot of negative thoughts that kind of get fixed in your head that are hard to get out, and they just play over and over again because your brain starts to kind of play tricks on you and get you stuck in this negative pattern of thoughts. Changes in movement, similar to sleep and appetite, it can be either an increase in activity or it can be less activity, where someone kind of seems like they're almost like moving in slow motion. It can lead to a lot of physical symptoms like pain, aches, just feeling very fatigued. It can lead to headaches, GI problems, and then in some people it gets to the point where you start to have suicidal thoughts. Next slide. So there are a lot of different symptoms. You don't have to have all of those symptoms to be diagnosed, but how if a mental health provider, primary care doctor would diagnose depression in someone is that these symptoms need to be consistently present for greater than 2 weeks, and really impair the functioning of the person, as well as be present most of the time. Of that list, you only need 5 of the symptoms to be diagnosed with depression. And it's important to note that to have a true diagnosis of depression, it cannot be due to another medical condition or substance use disorder. So in someone that is heavily using drugs or alcohol, not saying that they cannot have a depressed mood, but to call it primarily depression, you would need to treat the underlying substance use disorder. Next slide. So next we'll go into treatment for depression. So there's kind of 4 different areas I'm going to focus on: psychotherapy, medication, complementary medicine, and then brain stimulation therapy. Often the best way to treat depression is more than one of these in combination with the others. Next slide. Okay, so the first is psychotherapy. So this would be talk therapy. There's many different types of therapy, things like CBT, DBT, EMDR. So basically you work with a therapist, mental health provider, to help identify and change thoughts and emotions and behaviors. And going back to what I said earlier, that when you're very depressed, your brain kind of takes over and tricks your body into this negative pattern of thought where no matter what you want to do, you can't get past that. So working with a therapist can help identify that and kind of help you see that your brain is stuck in this pattern. And the therapy itself can be brief. It can last for a short amount of time during the acute episode of depression, or for some people, it's helpful to continue it long term. There's many different types of therapy, and it's important to kind of work and find someone that you feel you can have a good therapeutic relationship, because that's one of the most important factors in improvement. Therapy alone in people with mild depression is helpful. Often if it's a more severe case of depression, it's helpful to use therapy in combination with medication, which next slide. So overall, the kind of mainstay of medications, there's some different classes, but the ones that are most commonly used today are referred to as the SSRIs or the SNRIs. SSRIs work by increasing the serotonin in your brain. Common names that you might be familiar with are things like Prozac, Zoloft, Celexa, Lexapro, and Paxil. And the SNRIs work similar, but in combination with serotonin, they also increase they increase norepinephrine in your brain, and these are Cymbalta and Effexor and Pristiq. Usually one of those two classes is the first line that a psychiatrist or other prescriber would choose. With these medications, it's important to note that you may feel some improvement in symptoms early on, but to really fully see the benefits and see if they're truly effective, you have to wait 4 to 6 weeks, which can be difficult in someone that's very depressed. So that's where going back to using combination treatment, using these medications in combination with therapy could be helpful. There's other types of antidepressants that are also used. They fall under atypical depressions like Wellbutrin. Wellbutrin is helpful in kind of also increasing energy often, which is lacking in depression, and kind of give you that boost. And it can be used by itself or in combination with another antidepressant. And mirtazapine is helpful to use in combination often with one of the other antidepressants in people that are struggling with insomnia from their depression. And then there's older classes that I'm not really going to touch on because they're used much less common, and they're kind of reserved more for after you've failed other antidepressants, but just to be aware, they're called TCAs or MAOIs. Common side effects from antidepressants, it's important to note often that the side effects may be the worst in the first few days to a week, and some of them will actually improve with time. So if it's not to the point that it's making you so uncomfortable, it may be helpful to kind of wait that period out and see if they improve. But the common side effects are sometimes feeling a little more anxious or jittery or restless, having trouble sleeping, feeling tired, developing headaches or GI distress, anything. It's kind of nondescript. It can be anything from nausea, diarrhea to constipation. And then it can cause dry mouth and problems with sex. Next slide. And another area is that you can add in things that kind of complement or improve which can be helpful for people with mild depression in combination with therapy or medications, or in people that are also on medications, trying therapy, and it just feels like it's still not working. Because these are kind of seen as things that don't really produce much harm and just add a benefit to it. So things that are important to consider is diet and trying to eat as much healthy nutritional fuel as possible, exercising, which is easy to say, but if you're feeling very depressed and having really low energy, it can be really hard to actually get out and do that. So even just something as simple as taking a short walk can help improve depression. And then things like acupuncture, massage, hypnosis, which is a type of therapy, and then biofeedback. Next slide. And then the last area is something called brain stimulation therapy. So electroconvulsive therapy, or ECT, also kind of known as electric shock therapy, is actually something that is very effective. It's usually used more as a treatment in people that are treatment resistant, in the sense that they've tried a few different medications for an appropriate amount of time and they're still experiencing symptoms of depression and do not seem to be improved. Although it's highly effective, a lot of people have hesitation to it because unfortunately it's been portrayed by Hollywood as being a lot different than it actually is in reality. In reality, it's done under anesthesia, so it's a very peaceful process rather than what has been portrayed in movies like One Flew Over the Cuckoo's Nest. Transcranial magnetic stimulation, or TMS, is used to treat depression. It uses short bursts of magnetic pulses to the area kind of close to your forehead. And what the thought is it kind of helps to rewire some of those neural pathways and kind of help the brain get unstuck from some of that depression that just can't really get out. The biggest side effects with it is you may have a little irritation or headache after, but overall it's very safe. I should mention with both this and electrotherapy, ECT, it is a time-consuming process. You usually have to go for multiple sessions a week over multiple weeks, although you may feel some improvement earlier on. To complete the course, it's usually around like 6 weeks. And then vagus nerve stimulator, there's less evidence out there, and it's used very not as frequently, but it's supposed to help also with depression. Next slide. Okay, so now we'll kind of transition to suicide. Next slide. So suicide is a public health problem, and it's a leading cause of death in the United States, depending on which age group you're looking at. And hopefully and ideally, suicides can be prevented. The most important way to do that is through education and research to learn more about why suicide occurs. So the statistics we have here is from data that was collected in 2019 from the CDC. And to look at New York State, it's overall the 12th leading cause of death in the state. But then if you break it down by age group, in the ages of 10 to 34, it's actually the second leading cause of death. And then when you go into the next age group, 35 to 54, it's the fourth leading cause. And then ages between 55 and 64, it's the ninth. And then above 65, it's the 18th leading cause of death. So annually, there's over 47,000 deaths by suicide. And that makes up about almost 14 per 100,000 population. And then in our state of New York, it's 1,700, and it's about 8 out of every 100,000. We do rank as one of the lowest states as far as we have some of the lowest suicide rates in our state. Our state also has some of the best mental health services, which likely is the reason for that. However, according to overall even in our state with a lot of resources, many people have probably experienced that it's still hard to find services at points, and there's long waiting periods. And if you look at it from a national standpoint, almost 80% of communities feel that they did not have enough mental health providers to serve their residents, based on the federal guidelines in 2020. Over 6 times as many people died by suicide in 2019 compared to alcohol-related motor vehicle accidents. And of the deaths the suicides that were completed, almost 57% of those were by firearms. However, only about 27% of all suicides firearms were used. And so it shows that if a firearm is used, that it significantly increases the likelihood of completion of suicide due to the high lethality of it. Next slide. So risk factors, there's things that can be changed and things that are kind of just there and to pay attention to. So as I broke them down into 3 different categories. So first, as far as health, mental health conditions, so depression like we talked about, but all mental health conditions when untreated have a higher risk of suicide than someone that does not have a psychiatric diagnosis. Serious physical conditions such as pain and other debilitating conditions can lead to a higher risk for suicide. Traumatic brain injuries, likely due to when you have a traumatic brain injury, you can lose some of your impulse control, so it could be secondary to that. Environmental, so these are some of the things that if you're concerned, and we'll go into this a little further about yourself or a family member, that you can try to change to reduce the access to lethal means, including things like firearms, but also drugs, whether recreational drugs or prescription drugs or over-the-counter medications that are in your home, by providing them in a locked place that either the person doesn't have access to or requires an additional step rather than just being able to reach for it in a moment of distress. Prolonged stress, such as harassment, bullying, relationship problems, or unemployment, can put someone at risk. Stressful life events, things like rejection, divorce, financial crisis, or other major life transitions or loss. Exposure to another person's suicide, or to which can lead to like sensationalization of suicide, and then historically previous suicide attempts. So if someone has previously attempted suicide, they're at a higher risk of completing suicide in the future. Family history of having someone in your family history attempt or complete suicide, or things such as history of childhood abuse, neglect, or trauma. Next slide. Things that can, so those are the risk factors that some of them, like I said, can be changed, some cannot. And then these are events that can lead to kind of the person actually attempting suicide. So the recent death of a loved one, serious medical complications or issues, and relationship, arrest or legal issues, or homelessness, and financial instability. Next slide, please. So protective factors. So these are things when we look at someone and whether they're at risk for suicide, we look at the mentioned risk factors, and then we try to weigh those against the things that in their life that could be considered protective, so things that may stop them from completing suicide or attempting suicide. So having a feeling of connection to family, to friends, to some sort of community support, like support groups or a religious group, having reasons to live. So again, going back to family, friends, pets, children, access to mental health services, a purpose or meaning to life, which excludes external or internal factors, life skills or coping skills. So having a higher level of, frustration tolerance, that when something happens that's hard to cope with, the first reaction isn't to just reach for something to hurt yourself. Strong cultural, religious, or personal beliefs that discourage people from taking their own life, and then reducing the access to lethal means. Next slide. And then, so those were kind of individual that you could see, the person could see in himself, people can see, but these are some of the warning signs. So if someone that you love or care about is expressing some of these signs, this is where you should be concerned and really consider encouraging them to get help, or if you're to the point that you think they're actually going to hurt themselves, either bring them into a hospital or call 911 for some sort of wellness check. So if a person starts talking about killing themselves, they're feeling overly hopeless, having no reason to live, feeling that they are a burden to others. Often when people become very depressed to the point that they lead to suicide, they start to internalize those feelings to the point that they feel that the world around them would be better off if they are not there, as they perceive themselves to be a burden to others. Feeling trapped, feeling that they can't get out of the thought process they're in, no matter what happens, unbearable pain, and that can be either physical or emotional pain. Another warning sign is that if someone was speaking about all these things and all of a sudden they have this rapid improvement in symptoms, where all of a sudden they feel all better, they seem happy, and it seems very out of the blue, sometimes that can be a warning sign that the person has actually now put in place in their mind a plan to end their own life. And because of that, they're feeling some relief. And then there's also behaviors that may signal, especially if they're surrounding a painful event, a loss, a change, ongoing depression, so an increased use of alcohol or drugs, looking for a way to end their lives. So searching online for methods, talking to people, seeing what actually would be lethal if they use it to end their lives. Withdrawing from activities that they normally enjoyed, isolating from the people that they care about, sleeping too much or sleeping too little, visiting or calling people to say goodbye, or writing any sort of note that signals that. And then another warning sign is if someone starts giving away all of their important possessions, or aggression. Next slide. One of the most important ways that you can help someone or help yourself is to try to reduce access to means of suicide. This isn't saying that you or your loved ones firearms should be forever taken away from you. If you're in a place that you are feeling that you cannot keep yourself safe, or you feel that someone in your home could not keep themselves safe, it's usually a good idea to just give that firearm to a friend or a family member or someone that you trust, or lock it in a place and give the key away, just so you take away that direct access, because a firearm, when used, has the highest lethality of actually ending someone's life. Along with that, also considering storing medications, and not just the person's medications. If there's multiple people in the home, considering storing in a locked place other family members' medications and any over-the-counter medications, and may even consider having someone help you or help a family member to dispense the medications daily, so there's no access to a large number of medications. And also with medications, to discard any extra leftover medications that you don't need anymore. And if you're very concerned, it may be important to also lock up any other lethal means, so any really sharp knife, kitchen knives, anything that someone could use in a way that would be very lethal. Next slide. So now I'm just going to go through some of the options that when you or a loved one is feeling depressed or suicidal. The National Suicide and Crisis Hotline, it's a simple number, it's 988. And what that is it will connect you to someone who will help talk to you in the crisis. They will, if it's not something that can be dealt with over the phone, they'll recommend that you seek a higher level of care. So it's to go to a hospital, or if you don't feel that you can get yourself there, to call 911 and have someone come help you. Next slide. We have something more local. It's called DASH. It stands for Diagnostic Assessment and Stabilization Hub. So it's specific to Suffolk County. It works as a crisis hotline and evaluation. So you or someone you care about can call this number, and they will help assess you to see if this is something that can be dealt with through them, and make maybe recommendations for follow-up for level of care as an outpatient level, or if they are concerned that you need a higher level of care, they will have you come into a hospital to be evaluated psychiatrically in the emergency department. And if that number is available, that's a 24/7 number that's available. And then here at Mather, we have a few different outpatient clinics. We have the Mather Psych MD resident office. So that is where our psychiatry residents that are in training in their 3rd year of training spend the year seeing patients for medication management and some therapy under the supervision of trained psychiatrists. Then we have the Mather Psych MD office, which is a few different psychiatrists who see patients there. And then we have the Mather Mental Health Clinic, which is, it includes therapy and medication management. And then we also have at Mather, we do have an area of our emergency department that is for psychiatric evaluation. We have an inpatient adult unit, and we also have a adolescent inpatient unit, which is for ages 12 till they turn 18. We also have other outpatient services such as a chemical dependency clinic and a partial hospitalization for both adults and adolescents. Next slide. And then this link here is a place that you can find different services based on your location. You can also go through your insurance, and they will provide you therapists and prescribers that are considered in-network. Next. Okay, and this is our references. I guess we can open it up to questions.
Great. Well, thank you all so much for your extremely informative presentation. Yeah, if anyone has any questions, you could enter them in the Q&A feature at the bottom of your screen. Again, all questions are anonymous to protect your privacy. Do see some already. Someone asked if the slides will be available to print out. Yes, and we'll also have them on our website and on our YouTube page, the recording. Someone said, what is the success rate of each of the brain stimulation therapy treatments? At what point in depression should these options be looked at?
I will start with what point they should be looked at. It kind of varies from each one, but usually it's for depression, which is considered treatment resistant. It depends on the source that you look at, but treatment resistance is usually anywhere from failing 2 to 3 antidepressant treatments. Of the more traditional, like things like Prozac, Zoloft, Cymbalta, Effexor, so forth and so on. And for each one of those, you actually have to can be considered failed. You have to complete a course of usually 6 to 8 weeks without really any resolution of symptoms. So usually if that occurs, and this would be in an outpatient setting, then you may start talking about some of those other options. There's other options as far as also like using one of those medications and adding additional medication. So it's kind of an individualized discussion with your provider. ECT in particular can be used in the hospitalized setting in someone that is not responding to medications and remains actively suicidal, and there's concern for harm to self to the point that it may not be safe to wait out that time period of treatment for medications to respond. It can also be used in pregnant women, which points to its overall safety. And then as far as the effectiveness, would one of you guys comment on that?
It kind of depends on the patient, because a lot of our patients don't just have one mental health diagnosis. A lot of times there's substance involved, or there's other type of anxiety disorders that are present. So that's really common, and it's extremely difficult in the research literature to tease out like what is the efficacy rate with pure major depressive disorder with each of these. But as far as ECT is concerned, in general, as long as there's no other like substance or alcohol use involved, and if it's pure depression with suicidality, it's a fairly high success rate. But again, like those percentages they're too variable in the literature, but it's much higher than compared to medications at that point. TMS is a little bit less effective compared to ECT, and maybe just as effective as medication, but it's a different approach. So for someone where the medication isn't quite cutting it, TMS, the magnetic stimulation, might actually work for that individual. So it's more individually based, and it's difficult to comment on a broad sort of generalization like that.
And just to add to that too, typically sometimes even with like the ECT and DMS, you're still taking like some type of like psychiatric medication, or maybe you do have success with those treatments and you may not need to take the medications, but that's something that should be a discussion that you have with your psychiatrist or medication provider.
And also to add to what Dr. Stantek just said, I know with TMS in particular, since it's newer, all the research that exists that's currently published to my knowledge has always been the placebo part of the trial. So the people that weren't receiving the TMS were still on some sort of psychiatric medication because they felt that it was unethical to deny them of any treatment. So that kind of muddies the water as well.
Okay, great. Someone else said, how do you help a child who is 30 and doesn't feel like they have a problem? However, the person sleeps during the day, exhibits racing thoughts, can't get to work on time, limited interacting with family and friends. They spend most of the time in the bedroom. How can we get them help before they fall into a deeper depression?
I think that is a very, tough situation to be in. And sometimes it is, bringing to attention to that person, your concerns and worry. And if you are, further concerned, maybe seeking, expert, opinion and help on what the next steps could be and being knowledgeable of these resources. But, it sometimes is really hard for an individual who is depressed to see that this is where they are right now in their lives and be able to kind of have insight into that. And sometimes it does lead into more serious situations, but that's, the most important part is having the social support there being available to kind of point these things out and call for help when it is needed, even though the person may not feel at that time is needed.
Okay, great. I see some people are asking for the PowerPoint again. We could send this out to attendees after the webinar. I don't think there's any other questions. We could give it a second or two.
I mean, the one thing I did want to add is that suicide is not necessarily like preventable. I mean, the things that, you know, we really try to look at as like psychiatrist is looking at the overall history of individuals' symptoms and seeing what ways we can modify certain things. So I know sometimes there's a lot of family members that feel like, oh my gosh, I wish there was, you know, something I can do, and, you know, sense of responsibility, but you know, it's not really as preventable as we would like it to be. But there's things that we can do to kind of help that patient in the situation.
And going along with that, although we spoke about all the warning signs and the risk factors, sometimes there aren't really any warning signs, and that's what makes it a little bit harder to predict. Sometimes it just happens in people we don't expect it to happen in.
Someone asked if there's any local therapists you could recommend.
The mental health clinic has therapists, which is this third to last slide of this presentation. They do a combination of therapy and medications at that site. We, at the resident PsychMD practice, we do some therapy here. If you go to that samhsa.gov link that was also listed at the end of the presentation, you can type in your zip code and they'll list all of the places, and you can kind of just look for the therapists on that list too. So, and in addition, your insurance.
Is there a percentage of genetic disposition that makes suicide more likely than the other risk factors?
You may be able to comment more, but having a family member that completed suicide increases your risk for completing suicide. I don't know the numbers off the top of my head.
Yeah, it's not 100% clear what the numbers are, but it is clear that it is a higher risk if it's in your family, if you have someone, especially like a close family member, like a mother or father or a sibling. It increases your risk. It increases your risk of mental health issues in general. But like I said, depression doesn't just come by itself. Usually there's other things that are going on with it, either life stressors or alcohol, substance, anxiety disorders, and other things that are present, kind of adding and complicating the picture. But it does increase the risk.
There's a comment, someone asked, does yoga help?
Yes, definitely. I'm a huge advocate for yoga. Anything like that can, or meditation, it can help kind of slow the thought process in your mind. Yoga is great in the sense that it is both meditative, it's considered like moving meditation, and then depending on the type of yoga you do, it is also exercise. So it can be a great thing to add in to help with depression.
I mean, any type of like physical activity, deep breathing is excellent. I mean, it really is, especially there's some anxiety that is associated with the depression, like it kind of counteracts the like automatic heart racing. That's also a really great thing to be doing. But, you know, utilizing, you know, different types of coping skills too, trying to engage yourself and doing behavioral activation. I think that is really key to treatment. Like some days, you know, a patient with depression, it may be harder for them to pick up a toothbrush, but every time they pick it up, that's more like, yes, I got this depression, I did this today, and I'm going to keep doing it every day. So I think that's the most important piece of like trying to find simple, small ways of continuing to motivate behavior and, you know, help lessen the depressive symptoms and the lack of motivation that someone may have.
Okay, I see a few more questions are coming in. What would you all suggest to do when you're the caregiver and you're burnt out and, for lack of better words, over it, as all of your attempts have been failures?
I think the most important thing is to make sure that you're getting the help that you need. Sometimes it may be helpful to talk to a therapist yourself, to kind of have someone that you can openly talk about what your concerns are. Do things like try to get some time to enjoy hobbies, if possible, try to eat as healthy as you can, exercise, just really focus on taking good care of yourself, because if you're not doing well, it's hard to care for someone else.
Okay. Does the adolescent psychiatric unit have availability, and has the criteria changed to admit a young person experiencing suicide ideation?
The way to be admitted to our adolescent unit is to be evaluated psychiatrically in an emergency department, whether it is our emergency department or depending on bed availability and what's going on in our emergency department, we do take transfers from outside hospitals if they're clinically appropriate from other emergency departments.
But we do not have like an inpatient setting for children. It's just adolescents.
Yeah, it's 12 and above.
The adolescent population is very difficult to address the difference between a behavioral episode and a true suicidal episode. Often youth present suicidal with a plan, but when taken to ER or CPEP deemed not suicidal. Can you help us understand this?
So the one thing that I can comment on is whenever a clinician makes a decision whether or not to admit a patient into the inpatient setting, it's really looking at certain characteristics, whether that they meet a certain type of criteria. Sometimes when it is behavioral, you can't really change the behavior with medications. Instead, you'd be sedating someone and not really resolving that problem. So this is why, psychiatrists go through training to kind of observe and evaluate and figure out what is the best course of treatment. Perhaps maybe it is, being able to see a therapist, a specific type of therapist to help with these types of behaviors. But it's, if you have a concern, we're never saying don't come to the emergency room to become evaluated, but know that the clinicians are looking for particular characteristics and reasons of why an inpatient setting would be the most appropriate treatment environment. So we're always trying to look at the risk factors and see what the perfect setting would be for a patient to receive treatment. But if you do have questions, like when you are in this type of experience, definitely ask the clinician that is involved, the reasoning for their decision at that time.
Yeah, I think, just to add to that and sort of reiterate, suicidal thoughts come in, various sort of degrees. And, some people could, maybe have some vague thoughts, but not really have any intention of acting on it in the immediate future. And you really have to look at the benefit that could be had from a very short inpatient stay. So typically for an adolescent, the inpatient stay might be a week. If it's a long-term behavioral issue, realistically a week, and a medication adjustment is probably not going to do much. But if somebody is in acute danger to themselves or others, then perhaps a short stay on the inpatient setting could stabilize them, and then they would be discharged back to home.
And just to add to all of that, there are risks with admitting someone to a unit. It's not just all benefits, particularly in cases where it may be behavioral issues, because if these behavior issues are related to having difficulty dealing with stressors in the environment, whether in school or in home. And the adolescent spends time on this unit or any unit, and they really enjoy it, and it becomes a safe place. It can become a maladaptive coping mechanism, or a way that they use to cope, to get, like a break from the outside world, which then can lead to multiple hospitalizations and kind of put them into a system that maybe isn't exactly what is the most helpful for them. But of course, if there's acute safety risks, then all of that goes off the table and they're hospitalized for their safety.
And someone asked, does anxiety or depression cause vertigo?
Yeah, I mean, it can. Anxiety, probably more likely. Depression, typically not associated with it, but I have definitely seen patients who've had anxiety or panic attacks associated with it, and they will describe some symptoms of vertigo. It's not super common. It's more on, a lot less common, but I've seen it before.
If the brain is not feeling well, the body often will not feel well, or vice versa. If the body's not feeling well, it can lead to the brain not feeling well. So sometimes it's kind of hard to parse out exactly what is causing what.
What symptoms might require ECT?
ECT or ECT? I think ECT.
ECT or CT?
It says ECT.
Okay. Usually for depression specifically, it would be the treatment resistant depression that's severe, that's leading to the person really not being able to function in their life, or suicidal thoughts that are not improving with the standard treatments of medication or inpatient hospitalization, to the point that the person remains an acute risk to themselves.
There's also, catatonia as well.
Yeah.
It might not necessarily be just related to like a major depressive episode. It could be, someone who's catatonic, not eating, not drinking, or maybe the opposite, like a hyperactive catatonic patient. It's related to like psychosis. Sometimes we do ECT to help that patient. So there's various uses for it.
It's not just used for depression. It's used for many different mental health diagnoses. It's very individualized to the patient, because there's so many factors and everyone's unique.
I'm not sure if this is a question. Someone said a history of family suicide is not just DNA or biological, but normalizes suicide as a solution. What else? OCD suicidal ideations often mistakenly interpreted as depression, someone said.
Yeah.
All right, I think that might be it. I know we're short on time. Well, I want to thank you all again, and thanks to everyone for joining. If there are any additional questions, you could email them to matherhospital@northbell.edu. Once you exit the webinar, you'll also see a link to complete a survey. And if you could please complete the survey, your feedback is extremely important to us, helps us plan our future programs. Thank you all for joining today's webinar. And if you would like to view our other HealthyU webinars, you can find them at www.matherhospital.org/HealthyU. Have a great day, everyone.
Thank you so much.
Bye.